Organophosphate poisoning. The very name can send shivers down the spine of healthcare professionals and agricultural workers alike. This insidious condition, a consequence of exposure to common pesticides and nerve agents, disrupts the delicate balance of our nervous system, leading to a cascade of potentially life-threatening effects. Join us as we delve into the intricacies of organophosphate poisoning, exploring its causes, mechanisms, symptoms, and the crucial steps we can take to prevent and treat it. The primary cause of organophosphate poisoning lies in exposure to organophosphate compounds. These chemicals are widely used as insecticides in agriculture, homes, and gardens. Accidental or intentional ingestion, inhalation, or skin absorption are the main routes of exposure. Occupational hazards are particularly high for agricultural workers, pesticide applicators, and those involved in the manufacturing of these substances. Suicidal attempts also account for a significant number of cases. Furthermore, some organophosphates are employed as nerve agents in chemical warfare, highlighting the devastating potential of these compounds. Organophosphates exert their toxicity by irreversibly inhibiting acetylcholinesterase, an enzyme crucial for nerve function. Normally, acetylcholinesterase breaks down acetylcholine, a neurotransmitter that transmits signals between nerve cells. By inhibiting this enzyme, organophosphates cause acetylcholine to accumulate at nerve synapses. This overstimulation of cholinergic receptors leads to a cholinergic crisis, characterized by a wide array of symptoms affecting the muscarinic, nicotinic, and central nervous system. The continuous bombardment of these receptors disrupts normal nerve impulses, impacting muscle function, glandular secretions, and cognitive processes. Organophosphate poisoning affects populations worldwide, particularly in agricultural regions of developing countries where pesticide use is widespread and safety regulations may be less stringent. Farmers, farm workers, and their families are disproportionately affected. Accurate epidemiological data can be challenging to obtain due to underreporting and misdiagnosis, especially in resource-limited settings. The prevalence of organophosphate poisoning also fluctuates with seasonal agricultural practices and regulatory changes regarding pesticide use. The signs and symptoms of organophosphate poisoning can vary depending on the dose, route of exposure, and individual susceptibility. The classic cholinergic toxidrome involves a constellation of muscarinic, nicotinic, and central nervous system effects. Muscarinic symptoms include excessive salivation, lacrimeration, diarrhea, gastrointestinal cramping, and emesis, remembered by the mnemonic SLUDG. Nicotinic effects involve muscle fasciculations, weakness, and paralysis. Central nervous system effects can manifest as anxiety, confusion, seizures, coma, and respiratory depression. Respiratory failure, either due to bronchospasm, excessive secretions, or muscle weakness, is a leading cause of mortality. Diagnosis of organophosphate poisoning relies on a combination of clinical presentation, history of exposure, and laboratory confirmation. A detailed history should focus on potential sources of exposure, including occupation, recent pesticide use, and any suspicious circumstances. Clinically, the presence of the cholinergic toxidrome is highly suggestive. Laboratory tests can measure cholinesterase levels in the blood. A significant reduction in cholinesterase activity, typically greater than 50% of normal, supports the diagnosis. However, normal cholinesterase levels do not always rule out poisoning, especially in cases of delayed or chronic exposure. Confirmation with specific organophosphate compound detection in blood or urine is possible, but not always readily available. While not strictly categorized into types, organophosphate poisoning can be classified based on the severity of symptoms: mild, moderate, or severe. Mild cases may present with localized sweating, muscle fasciculations, and mild gastrointestinal upset. Moderate cases involve more pronounced muscarinic and nicotinic effects, with increasing respiratory distress. Severe cases exhibit profound respiratory failure, seizures, coma, and potentially fatal complications. The specific organophosphate compound involved and the route of exposure also influence the clinical presentation. The cornerstone of organophosphate poisoning treatment is prompt recognition and aggressive supportive care. This includes securing the airway, ensuring adequate ventilation, and maintaining cardiovascular stability. Specific antidotes include atropine, which blocks muscarinic receptors, and pralidoxime or 2-PEM, which reactivates acetylcholinesterase. Atropine is administered to counteract the muscarinic effects, such as excessive secretions and bronchospasm. Pralidoxime is most effective when given early, ideally within hours of exposure, before the organophosphate permanently binds to acetylcholinesterase. Benzodiazepines, such as diazepam or lorazepam, are used to manage seizures. Decontamination, involving removal of contaminated clothing and thorough washing of the skin, is crucial to prevent ongoing absorption. Activated charcoal may be considered for recent oral ingestions. Ongoing monitoring of vital signs, respiratory status, and cholinesterase levels is essential to guide treatment and assess response. Prevention is paramount in mitigating the risks of organophosphate poisoning. This includes strict adherence to safety guidelines when handling and applying pesticides. Proper personal protective equipment, such as gloves, masks, and protective clothing, should be worn. Thorough hand washing after handling pesticides is crucial. Education and training programs for agricultural workers and pesticide applicators are vital to promote safe practices. Storing pesticides securely and out of reach of children is essential. Public awareness campaigns can educate communities about the dangers of organophosphates and the importance of seeking immediate medical attention in case of suspected exposure. The prognosis of organophosphate poisoning depends on the severity of exposure, the timeliness and effectiveness of treatment, and the presence of underlying medical conditions. With prompt and appropriate medical care, many individuals can recover fully. However, severe cases can lead to long-term neurological sequelae, such as cognitive deficits, memory impairment, and peripheral neuropathy. Recent research focuses on developing more effective acetylcholinesterase reactivators and exploring neuroprotective strategies to minimize long-term damage. Studies are also investigating the chronic effects of low-level organophosphate exposure on neurological development and overall health.